So, first of all, thank you for having me here. I was first of all just going to talk a bit about my experience as a patient, talk you through a bit about myself, then go on to talk about more of the wider patient experience, and then some of the things that hopefully we can do to improve for patients going through this. So, in 1998, I was diagnosed with acute myeloid leukemia, and then as a result of this, I had an allogeneic bone marrow transplant. Unfortunately, this led on to me getting graft versus host disease, and this led to bronchiolitis obliterans. In 2002, I started working as a respiratory physiologist at Cambridge University Hospital with my colleague Carl over there. And actually, it was my 15-year anniversary on Saturday, so quite happy with that. After this, I got a couple of other issues with respiratory. I have the left-sided pneumothorax and then a right-sided pneumothorax. And then I had pleurodesis done through abrasion on both sides. And then after a long time of sort of being a bit in denial about what I was going to do, I had a therapy review and decided to optimise my therapy to try and improve my health as best I could. I just want to say a bit about my sister. So I'm very lucky that this girl is part of my life. At age 10, she was asked whether she would be my donor. She was a 98% match for me. And without hesitation, she said yes. The photo on the left there shows me and her just after having the donation. And the bag of blood is actually the bone marrow. So we've got that all in one photo, which is quite nice. One of the other good things that Daniela did was when one of her friends from school also asked or needed to have a bone marrow transplant, she offered to do the same again. And at 10, she was quite small, so she had very small hips, and that's the main place that you take the bone marrow from. Unfortunately, because of that, they had to go in both sides. So they say it's like being kicked by a horse. Well, if you have it both sides and you're 10, then it's quite a lot to go through. The picture on the right was us a few weeks ago, just to show that we're still very happy. A bit about my lung function. So my spirometry shows a mixed obstructive and restrictive picture. Body plethysmography shows that I have gas trapping through an increased RV, and then gas transfer shows that I've got diffusion limitation as well. When we look at my results of a hypoxic challenge, it shows that fairly normal at the start, but when I was exposed to the 15% oxygen, I did desaturate down to 85. My post-PO2 was 6.39, so that would be indicative of having oxygen when flying. And then moving on to the 6-minute walk test, you can see that as I sort of walk along, I do tend to desaturate, and I'm able to walk quite far. With my sort of adaptation to this, it's meant that I don't actually get that breathless. So my Borg score doesn't raise too much, and I'm able to tolerate it quite easily and still walk at a good pace. I just wanted to show you my chest x-ray. So it's fairly clear. Looks pretty healthy. So now talking about the various different flights. So one of the first flights that where I needed to have oxygen or have a look at it was in 2007 when we went to the ERS in Stockholm. The flight was approximately 2 hours. And what we decided to do was, at this point, was take a pulse oximeter on the flight, just to see how I responded. Did it represent what we saw in the hypoxic challenge? And what we noticed was that the saturation changes were not related to where the plane was. Saturation changes came as soon as they closed the door, and then I started desaturating from that point. I don't know if that's sort of a well-known fact, but that's what we noticed. One of the interesting things about Stockholm was it was also my first trip with Carl, and we went on an excursion one evening. We were sort of walking along. Now, Stockholm's pretty flat, but Carl managed to find a hill, and so he's merrily talking away to me. We're climbing this hill, and he turns to me, and I wasn't there. And he's looking around for me, and there's me up against the wall, trying to get my breath, and that's when Carl first realised that I probably wasn't quite as fit as I could be. His main worries was that he killed his junior physiologist on the first excursion that we went on. One of the other things that we noticed about the flight was that you tended to, because of the hypoxia, you tended to get a bit of a headache from being exposed to it over that length of time. And on the flight back, because I'd had that on the flight there, decided to drink more, stay hydrated, and actually that helped limit the symptoms that I got. So now whenever I fly, I tend to try and stay as hydrated as possible. The next flight was a little bit longer, so we went to Hong Kong and Singapore. The flight was approximately 13 hours. I did require oxygen for this, and when we went to pay for the oxygen, it actually cost more than the flight itself. And I had quite a few discussions with the airlines themselves because they didn't really understand the situation. What they wanted was to have a cylinder, which turned out to be about 6 cylinders per flight. Luckily, we decided to persuade them that we would use a conserving device, which meant that halved the number of cylinders that I needed, so I had 3 on each flight, but it still cost a good packet. One of the things about flying is that you probably all experience yourselves, is that it's quite a dry environment, and because of that, having rushing oxygen flow through your nose makes it even worse. So actually it was quite uncomfortable to sit there with that level of oxygen rushing through, especially if you don't normally use it. So it was something that I'm not used to at all. So sitting on there for that duration of time was pretty bad. One of the other things that happened while we were there was in Hong Kong, the air quality there was pretty poor. And when I got to Singapore, I started to get a bit of a sort of chest infection. It was really bad. I had to go and see a doctor out there, get some medication. Wasn't really prepared for it. Very bad fever. I was staying on a friend's floor. It was not the ideal situation. And then I came back to the UK, having sort of recovered, thinking I just had a normal chest infection. And actually, it turned out that when we saw the X-ray, I'd actually had a bacterial pneumonia. So that was quite a thing to go through and just sort of sit that out in a friend's house. Now, I think I'm probably quite lucky in that I'm quite young, fit, and relatively healthy. So I think that was on my side. I was able to push through, and probably because of the amount of exposure of how long I have the condition, that I was actually able to tolerate it. So I recovered from that, and then in 2008, we went to Jamaica. Again, it was approximately a 9-hour flight. We flew with Virgin Atlantic this time. Again, oxygen was required, but it was free of charge, so that made things a lot easier. The air, again, it was the recirculated stuff, and this, unfortunately, again, dried out my sinuses, so when I actually landed, it led to like an upper respiratory tract infection. But I was a bit more prepared this time. I had antibiotics with me, and so I was good for that. What also happened between this and the Hong Kong-Singapore flight was that I got a right-sided chest pain, or left-sided chest pain, and I went to the sort of doctor, got it all checked out. I had the X-ray done. They were worried that having had the pneumonia, that was possibly a PE, and so they did the sort of usual checks. Luckily, it wasn't PE, and so they basically just put it down to sort of maybe pleurisy. Got me to take some paracetamol, sent me on my way. And then when I got back from Jamaica, I got the same sensations. They then had a look back at the X-ray, and this is when they noticed that actually it was a pneumothorax. So this is the X-ray from the first setting before Jamaica. So you can see here the outline of the pneumothorax. And again, the one post in July, actually it shows it there and probably still bigger. So I probably quite easily flew with a pneumothorax, which I think is against guidelines. You shouldn't do that. So we were lucky that nothing happened. Obviously, with the expanding pressures, it could have made it a whole lot worse. But I survived. I'm still here. But once they'd recognised this is when it led on to me having the surgery. I had a chest drain. I had to go to Papworth Hospital and have all the surgery done. The next flight was to the ATS in San Diego. Again, it was approximately 9 hours. This time it was with United Airlines, and unfortunately, Organising oxygen this time was a lot more hassle. It wasn't provided by the airlines themselves, it was provided by a separate company, so you had to go through them. It was also quite expensive. When I got onto the plane, we pre-booked our seats, but unfortunately, because you couldn't have the oxygen cylinder underneath somebody else's chair, it had to be behind you. They moved me to the back of the plane, and this meant that I could no longer actually sit with Carl, which was a big shame. The other thing that the problem was the flight crew didn't really know what they were doing. So it's not very reassuring when you work in the profession, you know how these things should work, but the people around you aren't really clued up. And I think that's probably due to potentially a lack of training. I also had to be first on and also last off the plane. So all in all, there's a few interesting things. This is sort of like a word cloud of the European Federation of Allergies and Asthma Patient Association, or EFA. And these were sort of like some of the prominent things that came out from the patient experience there. But I'm going to read you some of the excerpts. So this is where it gets a bit more serious. This person said, "When I travelled back from Brussels, the steward said I should have booked a ticket for the concentrator. I thought he was joking, but he was not. He was serious. The airline wants to charge me over €1,000 for the round-trip flight. I don't think this sounds right, and I am so upset about this. This was supposed to be a wonderful family vacation, and it sounds like they are taking advantage of a healthcare situation. I think oxygen use in flights should be complementary for passengers, and all airline companies should have identical policies for all airline companies to make travel with oxygen easier." Now we get into some of the even heavier stuff. "Due to the turbulence, the stewardesses had to stay in their seats longer than I would have liked, as I needed the oxygen. Eventually, when they could leave their seats, they were more concerned with selling lottery tickets than getting my oxygen. I was getting more and more distressed as we watched the stewardesses discussing lottery tickets and drinks. In the end, my husband asked them to get oxygen. It was obvious they had forgotten. On her return, the stewardess was alarmed when she saw my very red face. She connected the oxygen to the cannula and gave it to me. She then asked if she should inform the crew of my condition as I looked so bad. I said no. I will be okay when I have had enough oxygen. 3 minutes later, I was distressed. As I could tell, there was no oxygen and the thought the bottle was empty. My husband looked and she had not even turned it on. Eventually, they let me through, but no one accompanied me. I ended up getting on the wrong plane, so I had to climb up another flight of steps to get to mine with my hand luggage. I got on the plane and was told by the steward that I couldn't fly because they had no oxygen. I showed him my letter and my receipt, and he argued like mad with me. By then I am sobbing. My friends came down the plane to assist, and others said how they had flown with me the week before and all was fine. The captain then appeared and told me I would have to get off the plane. I said, but I am fit to fly. He said, no, you're not, without oxygen, and we haven't any. I was then chucked off the plane. All in all, the stewardesses need more training in using oxygen. The bottles must be checked properly, as a faulty one for me could have had dire consequences. Now, if you get the chance, I'd probably go and read more about these stories, because actually there's more than what I've sort of said here. I think the other important thing to say is that this is probably highlighting the worst case scenarios, and we also know that there's probably actually a lot of people out there that actually travel really well and don't have any problems. So, and like myself, I have no concerns about travelling, so I don't be put off by it. So some of the other issues that might be faced, the airport layout, so they're large spaces. The departure gates are often long distances from the main terminal. This can require additional walking and also carrying hand luggage. And we all know that if we have to carry something, then that puts extra pressure on the body, that you have to deliver oxygen to the muscles carrying a heavier weight. Also, not all airports have moving walkways, which obviously reduce the degree of walking. And the other problem may be that if they have to change the gate, so you've made your way towards one and then all of a sudden have to walk in the other direction. In Heathrow, I just had a look at the different airports, a couple of them. So you could, after going through security, so that's not everything leading up to it, but past that, they say that there's anywhere between 200 and 800 metre walking distance. In Stansted, the distance, depending on how you get there, varies. So from the train, and if you go via the special assistance desk, can then be anywhere to just under a kilometre, just over. And if you go and park at one of the car parks, it's even further. So that could be anywhere nearly up to 2 kilometres. And I actually looked at how far I walked when I sort of got on the plane, and it was about 1,400 metres, which was quite a distance. Obviously, there are stops in between. Another thing to take into consideration is insurance. So you obviously need to declare your disorders if you've got sort of a general insurance, and they'll need to decide whether they can actually cover you. I updated mine before coming, and they just ask sort of routine general questions, like how many inhalers I had, did I use a nebulizer, had I been hospitalised in the last year, had I been on ICU within the last 5. Luckily, I can say that I was no to those last 2. They basically also may not cover some disorders depending on whether it's controlled or stable. It depends on the risk to the insurer, whether they take it on, and also it may cost you more to expand the policy up. Then there's the special insurance, which will cover most disorders, but it comes at a cost. It can be a lot. I have had some friends say that actually, and when I looked, it costs more than, again, the holiday itself. So we can already see that the costs are sort of going up and up and up. It may also cover only a single trip. So that's probably because if you have problems in between, they can't cover it for a whole year. But it is important to make sure that you do travel with full cover, because should you go to a health system where you have a problem, the worst thing that could happen is you get lumped with a large medical bills. I think I read that like a stay in America, just an overnight bed was around about £40,000 or dollars. The other thing that's good to have, I've left it down there, but the European Health Insurance Card. So when I was researching this, I sort of like stumbled across this, and I thought, I have to get this. So literally, as soon as I found it about 2 weeks ago, I sent off the form, filled out the details, and within a week, they'd sent me out the card, which was really good. And it gives you free access to state-provided healthcare during your holidays in Europe, and also Iceland, Liechtenstein, Norway, and Switzerland. And I guess soon the UK will probably be added to that list. Another thing to sort of take into consideration is respiratory infections. So you have the recirculated air, which is a mixture of fresh air and also recirculated by about 50-50. You have high filtration, but that's normally at the sort of bottom of the plane, and it can take a couple of minutes before it actually gets filtered. There was an interesting TED talk about fluid dynamics that looked at how air moved through the cabin and how it could be improved. So that's worth a watch if you find it. You've also got the temperature of the plane is cold, and it has a reduced humidity, and this can generate cold-like symptoms. And it can also then sort of affect people that suffer from sinusitis and rhinitis, which is similar to myself. Another thing to take into consideration is the air quality of the destination. So if we just have a look to see what that's all about. So there's an air quality index. The rate's different, and this has sort of become, it's now become a website, so it can be accessible. So if we just have a look to see what Milan is like. Not too bad. It's in the moderate zone, so it's 65. Zooming out a bit, just having a look at Europe, we can see that actually most of it is in the moderate, and then there's lots of areas that are actually good. If you then look down towards Turkey, you see that that's where you get more of the oranges and a few reds in there. On a larger scale, looking at the whole world, we see actually that there are some places that are good, but there's also some places that are really bad, and also there's a lot of areas that aren't actually covered at all. Funnily enough, if we look to where Hong Kong is, we see that the reason why I probably got the chest infection or the pneumonia was because it's in the red zone. Funnily enough, I also did a master's a couple of years ago, and I had to stay in London. And in the UK, the only orange one is in London. It was probably the worst prolonged year that I had with my chest in a long time. I got hay fever for the first time, and it wasn't that much fun. But I did have a great time doing the masters. So it's important to check the destination for the air quality and the allergens if you're sensitive, because obviously you don't want to travel to somewhere and find out actually that they're going to give you more problems with, say, if you have asthma. You can check the website should you need to. The other thing to have in place is probably a management plan. So you want to discuss with your doctor what issues you may face, prepare for the trip with preventative medications, and you also want to plan for the most common ailments with like rescue medications. So make sure that you've got antibiotics and steroids to take before you go. The destination, so you may be restricted on where you can go because oxygen's only available with certain operators. Some short-haul flights do not offer oxygen at all. And actually, I heard not so long ago that some flights that are currently offering it are potentially taking it away in the future, which isn't good. Also, long-haul flights, they may not have therapeutic available oxygen available, and this will mean that there will be a cost. And it also depends on which compartment you're actually flying in. So you have to be, not that I think many of us would be able to afford first class, but you can't get oxygen there until you're actually flying. They can't give it to you before or after. Whereas if you go economy, well, actually we're quite lucky, we can get it throughout the flight. You also want to make sure what medical facilities are available in the place that you're going to. So are you visiting a small rural town or a large developed city? Will they have a local doctor or is there a hospital in the vicinity should the worst happen? Or are you able to manage your own condition? So these are all important things to sort of take into consideration. You also need to understand the health system of the destination that you're going to. So does it have a free health service, which may depend on your citizenship? Is it an insurance or payment required type system, or is private healthcare available where you can just go and actually pay for your treatment straight out? For patients travelling, my recommendations would be to make sure you check your online resources. So the British Lung Foundation had a really good website. It covered how and where to go, like where you're travelling to in the UK, what to do if you're going abroad. It had like practical issues that you may face. So if you've not had the discussions with your doctor, it's a good place to go. There's also a checklist on there to make sure that you've got everything that you need before travelling. There's also useful contacts, and it has downloadable resources as well, so you don't have to just have access to it online. Say if you go into a place without internet, if you downloaded it before, you'll be able to check that. Again, the European Lung Foundation also has a very good website, slightly different perspective. They've got a section looking at the fitness to fly test, which we recently did the video for, which was good fun. It also tells you about arranging special assistance, how to go about getting your medical certificate. There's also an index of the different airlines. So you can scroll through them and see what they provide and what their website is, and just check all their information, like what medical assistance do they provide. There's also a section on air passenger rights, so it's like what are your rights for travelling, which is also worth a look. Again, I said that there's the hypoxic challenge test video, so should your patients want to know what they have to do, it's a good place to go to see what they want to do. European Federation of Allergies and Airway Disease Patient Association, which I don't know how that got shortened just down to EFA, but I think they need to have a shorter name. But they produced a booklet called Enabling Air Travel with Oxygen in Europe, which was really useful. That's where I got the patient information from. It gave very detailed information about the airline's oxygen options. So it included like the oxygen policy of the airlines, how you go about requesting it, the different flow rates that they offer, the costs, whether it was portable oxygen bottles or the concentrator. The thing you've got to be careful of is that you cannot get oxygen through security. So you've got to arrange it with the flight airline themselves so that they can have it on board for you. Although recently EasyJet has just said that actually if you have a letter, they will allow this. I'm not sure how that works, but it's worth investigating. So again, you want to check the airline website details and also check their individual medical page, because there are differences between the airlines. It's not a universal thing. Make sure you check your information before your flight to avoid any disappointment. The last thing you want to find out is that you've booked everything and then you can't have the oxygen, because then you're in trouble. You'd lose money and all that sort of thing. And that's probably not covered by your insurance. Additionally, there was also a website in Australia. I couldn't find any information for America or Asia specifically, so they probably need to bring on some information soon. My other recommendation is probably to improve awareness. So most patients do not think of mentioning travel to their doctor, especially if they don't have oxygen. Normally they think, well, and also they're unaware that actually when you're in the plane, it's a different environment to when you're on the ground. And actually, when I started promoting the video, I put that on Facebook, and one of my friends said, I should have seen this video before I went on my holidays. Now, she actually sleeps with oxygen overnight, but it hadn't even crossed her mind that it might be something that she needs when flying. Luckily, she's back safe and sound, and she had a good holiday, I think. So one of the things that's going to probably hopefully come out of this is that the ELF are trying to generate a poster for putting up in clinical areas. So that will go up in your respiratory physiology departments as well as your clinical areas, patient receptions, GP practices, and then hopefully it'll just trigger patients to actually think about it before they go and see someone, and then hopefully that will start the discussions. Also, we need to promote it as healthcare professionals and also with the patient organisations as well. From the airline's point of view, they need to make sure that you're planning your travel appropriately. So you want to investigate the requirements of the airline for special assistance before booking, make sure that they can accommodate you. If the oxygen is required, you may have to book a hypoxic challenge test, and this has to go through your clinician early. So with a respiratory physiology hat on, the departments are getting quite busy, and these tests can take quite a while. If we're booked up, we cannot do the short, quick, get you in, get the test done. Especially if we get notified 2 weeks before you're due to fly. It's a bit tricky to sort of arrange it all in that sort of time. Also, your oxygen requirements may change depending on an improvement or deterioration in your clinical status. So when I said about optimising my therapy, when I've redone the hypoxic challenge, I didn't desaturate to the same levels that I did when I had it in 2007. Also, you need to check that you cannot travel with your own cylinders, as I've said earlier. But most airlines will allow a portable oxygen concentrator. And they do carry onboard oxygen, but again, you need to check with the airline. You need to prepare yourself. So make sure that you stay hydrated. And this is probably good advice, not just for patients, but for everybody. You also need to take the medical precautions. So you take your prophylactic antibiotics, as well as anticoagulants, to make sure that you don't get any thrombosis, flight socks, and then there's also a recommendation for decongestant nasal sprays, just to make sure that you don't get a build-up of any sinus problems. With the special assistance, so airlines can offer assistance and also the airports, but you have to go through your airline in order to arrange this. And quite often they can assist with a range of different things, so such as mobility aids and wheelchairs. They can also give you specific seating requirements. If you've got any visual or hearing impairments, if you're travelling with assistance dog or a medical assistant, they can arrange that. They can also assist with medical conditions and medications, but check their website for details. You can also get assistance at the airport, so should you need ferrying around. And also they have the dietary requirements. You want to make sure that you notify them at the time of booking, or at least 48 hours prior, because otherwise then you won't be able to get it arranged. They can arrange for you to have assistance with your luggage, and I think this doesn't just mean putting it in the hold, but I think it's also they will help you with your hand luggage around the airport. So that's something to take into consideration. If you do have to travel with a guide dog, they need to be registered with a pet travel scheme. So I was unaware of this. I don't know if they let you in the cabin without your dog or how that works, but the other thing to sort of think about is the medical information form, and this needs to be completed for travel. So it's done in two parts. The first part is done by the patient or the airline travel company representative. The second part needs to be completed by your consultant or doctor. So it's important to make sure that you know about these forms early, because you need to make a time and arrange it with your doctor to get them filled out. Also, the medical forms differ dependent on which airline you go with. So it's not a universal form. Each one's got a slightly different layout. They will ask different questions depending on who you're flying with. They may also require you to have had the hypoxic challenge before you can actually fill out the form and get your oxygen. So that's why it's important to get all this stuff done early when you're planning. So in summary for the patient, I recommend that you plan your trip early, just to ensure that you get adequate assistance provided by the airline and the destination. Discuss plans with your clinician. So it's important to implement management plan if suitable. Check your insurance cover. Also use the online resources available through the ELF website, BLF, and also the airline and airport websites themselves. You need to prepare yourself as a patient, so you stay hydrated, flight socks, and also the nasal spray decongestion. From a clinician's point of view, we need to improve patient awareness within the clinical environments. So this will be the posters in the clinics and also discussions during clinical reviews, making sure we're having these conversations with the patients. I think it's similar to sort of sleep. Patients don't always get asked about sleep, so they're even less likely to get asked about whether they plan to travel. It's probably not on most patients' radars. We need to request hypoxic challenge tests early to make sure that we can get them booked in. We probably need to have a review of the current guidelines to make sure that everything's up to date, and also use online resources. I think probably also we need to work closer with the airlines and airports and everybody else, probably all those that are in this symposium, just to make sure that everything's as good as possible. But thank you very much, ELF and ERS, for getting me here. And yeah, that's it.
Thank you very much, Matthew. That was absolutely terrific. We can take a few questions if there's anybody. If you could just go to the microphones, please. We'll try and get you in rotation.
Hi.
Okay.
Stephen
First
Gill from Calgary. I'm wondering, I've never seen any information on how concentrators function at lower pressures. Can you be certain that the portable concentrator will actually deliver adequate oxygen in an airplane?
That's not something that I've looked into when I was researching this. I think it's something that, again, I think with probably like a lot of things, there's more research needed in a lot of areas, like how the patients function. I couldn't comment about pressures with the concentrators.
Okay.
Kendrick, Bristol. Thank you. Excellent talk. I have one comment. I've had a number of patients who getting them to their destination required a hypoxic challenge test. One of the things that we often forget about is where they're going and what they're going to do when they get there. I had a patient who was flying out to trek to Machu Picchu. She needed oxygen on the flight. She would have also needed oxygen to get to Machu Picchu. So I think if we're looking at educating our patients, it's not only about how you get there, but also to work out what you do when you get there. And for that particular patient, I actually exercised her at 10% inspired oxygen on a treadmill, and she failed the test miserably. But I think it's important that we bear that in mind as well. It's not just about how to get there, it's what some of them are doing when they get there.
Yeah. And I guess also the altitude of the destination.
Lady in the middle.
Yes. Hi, I'm Daniela Koch from the Netherlands, pulmonologist. Thank you for your presentation. When you do the hypoxic challenge test, you set your saturation level or your PaO2. If you see that the patient is getting tachypneic, using the accessory muscles to breathe, but just gets the right saturation level, what do you do?
Is it right if you could repeat the question a bit louder? Sorry, I couldn't.
Oh, sorry. The patient stays above the level of the saturation that you spoken for the hypoxic test, but the patient gets tachypnoic during the test and also using accessory breathing muscles. So I'm like, okay, you get the saturation level, but if your flight is going to be 9 hours long, how are you going to be breathing like this for 9 hours long?
I think it will depend on the patient's breathing pattern and probably needs to be assessed as part of the assessment. I think that's also probably part of the reason why patients also get dehydrated when because they are breathing at a quicker rate in order to try and ventilate more. To be honest, I couldn't say what we should be doing, whether we need to maybe extend the hypoxic challenge test to sort of make sure that patients can cope for a longer period of time to see if they're getting tired.
Because it's something... Hello? Yeah. It's something I have in the back of my mind because I also work at a department of home mechanical ventilation, so we have a lot of people with muscle disease. And they're not on ventilation yet, but they still go flying. And results have shown that even though they have a right saturation at sea level, they can still desaturate during the flight because they cannot compensate. So I hope that the information that will also be available for the rest is also taking an account for the muscle diseases.
Yep.
Thank you.
Thank you.
Okay, one last question over here. Thank you.
I am Dr. Mozaffari, pulmonologist from Iran. How do you detect the respiratory problem in passengers? For example, do you recommend to fill out all of this questionnaire for all of passengers?
I think it's very hard. So actually, when I'm in the plane, I don't notice any difference at all with my breathing, and a lot of it's the sensation. I don't get any sensations at all for breathless that you would associate with having saturations that are lower. And I think that's also part of the problem. So patients will go on these flights and they'll be walking about a cabin and not necessarily getting they might be getting the same symptoms that they had, but they're not unaware of the levels that they're probably actually at. And I think that's probably another cause for concern for air travel in general, is that there's probably, at the minute, a lot of patients that are travelling that are unaware of what's actually happening. I guess the other problem is we don't know the long-term effects of them doing this sort of travel. So it's whether we need to look at other things, maybe longitudinal studies to see if there's any after effects afterwards. But yeah, without doing actual monitoring, there is no way of looking, so we'd probably need to do more research in the actual plane environment.
Okay, Matthew, thank you very, very much. Excellent.